And thank you very much for joining on a Saturday morning. And it's an exciting session for us, and I'll explain the context a little later. But just to set the ball rolling, I mean, you're here in the 5th of the Thought Leadership Series of Social Venture Partners India. Most of you know SVP India was set up 5 years ago by Ravi Venkatesan. I took over as chair 3 years ago. And today, I think we are fortunate that it's a very large global community, 12 countries, 3,600 partners worldwide, and very actively engaged in various issues of the world. Which is why I'm most excited about SVP today, because fortunately, and I say this very consciously, you can't say fortunately in a world where 4.5 million people have been affected by COVID, and I believe the India count has crossed 85,000. But the fortunate part has been that we're already seeing the new narrative in play, where we are able to engage very frequently with people who would otherwise we would find it difficult to have a conversation with. And I think for me personally, it's been an eye-opener in terms of the possibilities that we are seeing here. And in SVP itself, if you look at it, I mean, we were primarily, and we still are, primarily 7 chapters engaged largely in local initiatives. We have one national initiative, which is in partnership with the Tata Trusts, which is what we call the Million Jobs Mission. And we have nearly 40 nonprofits whom we are working with to really make that million jobs and sustainable livelihoods happen. But today we're finding that sustainable livelihoods will not happen in isolation. Reading the papers with the clamor for getting out of the lockdown at some point, we are finding that sustainable livelihoods happen when demand gets created. Demand gets created when supply gets created. Supply gets created properly in this country only when the supply chains, the migrant labor, everything gets re-established. So we are in a cycle where there is a lot of connectivity. And I think it's important to realize that and make sure that we are engaged in all aspects of economic growth, which is why this Thought Leadership Series, because we started with our global chair, Sophia, and Arun Maira, former member of the Planning Commission and a member of our board, who actually talked about a systems way of thinking about the problems and introduced the concept which we are now propagating called moving from relief to recovery to resilience, which is so important for all of us. We explored the theme of resilience further in a very interesting session by CSR heads, which was chaired by our Bombay chair, Amitabh. Then Gaurav, who's our Ahmedabad chair, and I actually talked to 3 of our very successful nonprofits in terms of how they are building their resilience team. And just 3 days ago, we had Ajit Rangnekar, our Hyderabad chair, moderating a session which had Mehak Padamji and the chair of SVP Melbourne, Mark Jankelson. We talked about leadership in a time of crisis, which brings us a session which we are very, very excited about. Because we said that, look, SVP is above all an organization. In SVP India, we have over 300 partners. And each of us has a point of view. We are not afraid to air it. Really need evidence-based, authentic, and we'd love to have that kind of conversation. And Jogin, who's our Bangalore chair, and I'll introduce him in a minute, was kind enough to suggest that let's get a couple of other scientists. He's a great scientist himself. But 3 scientists in conversation on understanding COVID better, understanding how to fight the battle against COVID, and tips that they might have to make us think and perform and behave in a better way to fight COVID. Part of the session. I'll very quickly introduce Jogin. Jogin, as I mentioned, is Social Venture Partners chairperson in Bangalore, which is our largest chapter at this point of time. He's also the founder and CEO of iSystem, which is a cell therapy company developing scalable cell replacement therapies for the world. Prior to iSystem, Jogin was part of the global leadership team at Quintiles from 2001 to 2007. And more recently, he was a CEO of Senduit, the world's largest standalone randomization company, a joint venture with Thermo Fisher Scientific. Dr. Desai is also the co-founder of Ignite Life Sciences Foundation, something we were all very excited about, a not-for-profit scientific research institution that funds and enables scientists to pursue their research projects in an uninhibited and uninterrupted manner. So we're really excited, Jogin, to have you with us. The ground rules, ladies and gentlemen, for this session is, we will let Jogin handle the entire session for the next hour and more, and get the other scientists. He'll introduce them in a minute. to talk about their own viewpoints. We will get about maybe 10-15 minutes at the end where I'll moderate a question and answer session. Please feel free to post your questions on the chat line. I'm sure by now all of you are very familiar with Zoom, so that I can kind of consolidate and ask some interesting questions at the end. And then we'll close the session. So thank you very much again for being there, and over to you, Jogin.
Thank you, Ganesh. And you've equated between Cherry and Shahid, which as I am not a scientist. These guys are the scientists, just so you know. But thank you, Cherry. Thank you, Shahid, both of you, for graciously agreeing for this session. I will introduce you guys right now. There's a lot of noise muting. I hope everybody else can mute themselves so that we can hear a little bit correctly. Okay, that's better. Thank you. So Dr. Shahid Jameel is the CEO of the DBT Wellcome Trust India Alliance since 2013. He also serves with me on the board of Ignite Life Science Foundation. Prior to this, he was instrumental in setting up and leading the virology group at ICGEB in New Delhi for 25 years, where his research focused on human viruses, especially the hepatitis virus. He was elected fellow of all 3 Indian Science Academies. His research has been recognized with many awards and grants, notably the B.M. Birla Science Prize in Biology, the Shanti Swarup Bhatnagar Award in Medical Sciences, and an International Senior Research Fellowship of the Wellcome Trust in the UK. So welcome, Shahid, to this session. I will introduce Gagandeep Kang, known as Cherry. Cherry is the Executive Director of the Translational Health Sciences Institute at Faridabad and a fellow of the Royal College of Pathologists. She heads the Wellcome Trust Research Lab at CMC Vellore and is again on the board of Ignite Life Sciences Foundation, an accomplished scientist and leader with many honors to her credit, elected as the Fellow of the Royal Society, a member of the Product Development Vaccine Advisory Committee at the WHO, and chairs the Immunization Technical Advisory Group for WHO's WHO's Southeast Asia region. She serves in many national and international committees, and I've saved the best for the last. She helped develop Rotavac, India's first indigenous vaccine against rotaviral infections. So welcome, Cherry, to the group, and once again, thank you both of you. I will start with a high-level question. Maybe start with, so for everybody else in the group, the way it will work is Cherry will address this entire crisis from the infectious diseases and the epidemiology perspective, while Shahid will talk from the virology perspective, because this is this is their expertise. So Cherry, maybe start with you. From where we are, what do we see, where do we see the crisis? What do we see the role of science itself? Once we start with these high-level objectives, we'll start going into the details, including, I'm sure, questions that a lot of people will have. So, Cherry, over to you, and then Shahid next.
Sure. Thanks, Jogin, for the introduction. I thought I'd just take 5 minutes to highlight from a medical scientist's perspective how this infectious disease is a bit different from everything else that we've seen. A lot of the things that I'm going to say is what people already know, that this is something we've never seen before. It was a pandemic that many people predicted would happen. The world essentially ignored it. And we are in a situation today where we decided that efficiency was everything, and we did not leave enough room for surge capacity and resilience. And this is important for all systems of society. But what I would like to emphasize is how much we have learned with the science that we have brought to this situation in the last 5 months. Going from a stage where we had a new pathogen that nobody knew anything about, we are at a stage where we actually understand a lot about the biology of the virus, but we are also every day understanding more and more about how to manage a virus that we did not know anything about. We started initially with tools that were already available to us, tools that are not new, tools that have been used since the Black Death in Europe in the early 1300s. The idea of quarantine, the idea of isolation, the idea of testing, tracing, and making sure that we remove from society for a while the people who are infectious. Now, this is not new. We've applied it to a range of diseases. All infections that spread rapidly can be handled in a similar way. But then we think about what are the tools that would allow us to move to the next step. And those tools are, how do you better identify cases? One of the most important things about this infection is that unlike SARS, which we saw in 2003, this infection can spread from people who are asymptomatic. Once you have an infection that spreads asymptomatically, you wind up in a situation where elimination and eradication become nearly impossible because the virus has a place to hide within human beings. So that's why making sure that you have a diagnostic that can pick up people who are currently infected as well as document the history of infection is important. If we look at the next area, which is how do you treat people? For most viruses, actually, we don't have a specific therapy. And until HIV came along, we didn't focus very much on the development of antivirals. Now, the research that was done for HIV essentially transformed the field in our ability to look at viruses, to look at what point can you arrest the replication of viruses. So what is happening currently, using tools that are old and using tools that are new, such as artificial intelligence, we are able to identify from our libraries licensed compounds as well as new chemical entities that can be taken forward for development. Some of these are already in clinical trials, and some of them we are already getting evidence from clinical trials that they don't necessarily work. Hydroxychloroquine is a case in point where it looked like, based on cellular studies, that this would be an approach that might work to inhibit virus replication. But when we actually got into the clinic, we found that maybe it's not going to be that great. And the trials we've had so far have largely been negative ones. Similarly, we have remdesivir, which is a drug developed for Ebola, then tried out in MERS, currently in clinical trials. One published study showing it doesn't work very well, a report from the NIH saying that it does do good, it shortens the duration of illness, but this is not a wonder drug. This is not curing the disease. It is shortening the duration of illness in very sick patients. So these are the kinds of things that clinical research needs to be thinking about. Not just the therapies that are already available to us, but also what are the new tools that we can bring to bear. I don't know if all of you remember some of the videos that we saw of the teams in China that went around doing tracheostomies to start patients on ventilation really early. They were really scary pictures. And now, the whole world scrambled for ventilators. Now we understand that if you actually wind up going on a ventilator, your chances of survival are relatively low. So we need to be thinking from a clinical perspective about how to keep patients off a ventilator for as long as possible. And then finally, coming to vaccines, we've never seen something like the effort that is being made for vaccines until today. There are 133 candidates that are in development. There are about a dozen that are leading candidates, and everybody is desperate because we recognize from an epidemiological perspective that until a certain proportion of individuals develop immunity to this virus, and that could be through natural infection or could be through vaccination, we really don't have solutions as a society. So I will stop there and hand back to Jogin. I'd be happy to take questions later.
Thank you, Cherry. This was extremely helpful. This is a fantastic overview. Very, very well done. Thanks. The one thing I will add before handing this to Shahid is that from the clinical, I come from the clinical trials business, where we are fond of saying, unfortunately, that 8,000 candidates are identified and one gets into the market. So I'm hoping we are going to be different in this case, but that's the reality of it. So thank you. This was a fantastic overview. Shahid, I'll send this over to you from the virology perspective of the disease.
Thank you, Jogin. Can you hear me loud and clear?
Yes, we can hear it perfectly. Thank you.
Okay, wonderful. Well, first, a little reality check here. As was mentioned earlier, we have 4.5 million cases with a little over 307,000 deaths as of today. And between yesterday and today, India has just passed China in the total number of cumulative cases. We stand at 85,749 cases. China has something like 84,000 cases. Our mortality is roughly 3.2%, the case fatality ratio, with 2,753 deaths. The case fatality ratio is not something we should really be too worried about, because this is already a selected figure. These are the number of people who are confirmed positive who are dying. So this is not the population mortality ratio, which is something very different. And we have written about it, and there are other studies that suggest that the population mortality is likely to be in the range of about 0.5, 0.6%, which means that there are a number of infected people who are never tested simply because they have either asymptomatic infection or infection that is very mild, and therefore they never really get to a clinic. And also looking at the testing norms in the country, many of these people wouldn't be tested. As of today, India has done about 2 million tests, and we continue to be one of the lowest in terms of numbers of tests per million population. It's not really the number of tests which is important. It is more important how you test, what is your strategy to test. Are you able to pull out pockets of infection from the community, and then how you manage those cases. Looking at the figures for different states of India, there are a few curious things that light up. Maharashtra, for example, has the highest numbers of cases. Roughly a third of cases from India are from Maharashtra. And about little less than half the deaths are from Maharashtra. Gujarat, Tamil Nadu, and the Delhi National Capital Region also have, also make the top 5 in terms of number of cases. Curiously, West Bengal shows very high mortality. If the average mortality figure for the country is 3.2%, the case fatality ratio, West Bengal shows 9%, so almost 3 times the national average. And this is really worrisome. One would have said that it is because West Bengal may not have very good healthcare facilities, but that's not true. West Bengal is really one of the top states in terms of number of hospital beds per million population. On the other hand, Bihar, the mortality is only 0.7%, and we know how badly broken the healthcare system is in Bihar. So clearly something is amiss here. Possibly West Bengal is reporting mortality much better because of a better healthcare system compared to Bihar, which is just not reporting. People are dying and it's not being reported. So these are things to keep in mind. We can't really look at India as a single entity. And also when we're trying to control the outbreak, we can't look at the country as a whole. The reality of Delhi and Mumbai is very different from the reality of Arunachal Pradesh, for example. Population densities are different, the mobility is different. So we must really be, while we are thinking globally, we need to really act locally. The other question is, has the lockdown worked? Well, to some extent it has, because if you look at the figures, if you look at the doubling time of the outbreak, on 25th of March, when the lockdown started, the doubling time of the outbreak was 5.4 days. Today, the doubling time of the outbreak is 14 days, 14 days. It went through a peak around the first week of April, when the doubling time went down to about 3 days, 2.5 to 3 days, and then it started getting better. So now the key really is how we figure once the lockdown are gradually eased, and what will be critical is proper messaging to ensure that people comply with the guidelines. A little bit about the virology of this virus. It's what one calls an enveloped virus with an RNA genome. It's an enveloped virus because the shell of the virus is surrounded by a lipid membrane with some proteins in it. And being a lipid membrane, it is susceptible to soap and water. You all know that oil disperses with soap, and that's why washing hands with soap and water is the most effective way of sanitizing yourself. The progress on the virus has been remarkable. Cherry talked about vaccines. Within 5 months, we have more than 130 candidates, about a dozen of them in advanced phase of development and testing. The other success really is that since the first sequence of the virus was provided by China in early January, at this time we have more than 25,000 sequences, genomic sequences of the virus from all over the world, which are publicly available, openly accessible to anyone to take and do all kinds of analysis and modeling. And what people have shown is that the virus, of course, divides itself into multiple groupings or clades, but it would be wrong to say that there are multiple strains of the virus. So if you keep hearing that, in India, the numbers are low because we have a weaker strain of the virus, that is completely not true. There is a single strain of the virus floating around. It has different groups, different clades. Most likely scenario is that the virus jumped from bats to pangolins to humans. And I say this because of two key features in the virus. There is a surface protein in the virus, which is called the spike protein. And this is the protein that is required to make contact with the target cell for the virus to enter. And in the spike protein, there is a region which is called the receptor binding domain. And the receptor binding domain of the COVID virus looks very different from the receptor binding domain of even the Sars virus that came in 2003. And also its closest common ancestor, the viruses that have been discovered in pangolins or in bats. There is also another feature of the spike protein, which has a cleavage site and some basic amino acid residues around the cleavage site, which is also quite characteristic of this virus and is missing from all other coronaviruses. Which also takes us back to influenza virus that we know much more about. And it's been seen in influenza viruses that when these viruses go from a low pathogenic virus to a high pathogenic virus, they acquire this polybasic site. So this is not good news. This tells us that the virus has acquired the capability to infect human cells very well. Those human cells that have the ACE2 receptor on it, and there's a wide range of human cells that have ACE2 receptor on it, all the way from cells in the nasal cavity to lungs, to intestine, to kidneys. And some of the clinical manifestations that we've been seeing, the multi-organ manifestations, may be the result of this. The second thing is that the virus has acquired the capability to transmit very effectively between humans and to cause serious amounts of damage. We still don't understand what are the correlates of protection. What sort of antibodies do you need? Do you just need antibodies to protect, or you also need cellular immunity, T cells, for example, for protection? So those things are being worked out, and there's a tremendous amount of information that has been generated so far, but we still have much more to know, much more to learn, both about the disease manifestation as well as the biology of the virus. So I will stop there and maybe wait for questions later.
Sure. Thank you, Shahid. This is a fantastic overview. Thanks so much for this. I will then loop this back to Cherry. Cherry, what's your idea of, I mean, there's been talk about a first wave, there's a second wave, and so on. So can you help us get some sense of it? Of how do you see this progressing?
So if you look at what we saw in China, that was really largely a single wave, and what we've seen with every other country as well has been there is a lag phase where numbers of cases increase very slowly, and then they increase exponentially, and you peak, the system is overwhelmed, and then the number of cases starts to come down. So that's your first wave. Recently, there has been a lot of mathematical modeling done by people that I have worked with in various capacities. And they are people that I really respect in the modeling field. And what they've come out with, what sounds really plausible to me, is 3 scenarios. And these 3 scenarios are, this is the first wave, we've had the first wave, this is going to be the biggest thing that we see. And after this, we are going to continue to see a reasonable, peak and ebb pattern that will continue for the foreseeable future, where over time the peaks may become lower and this virus might behave like influenza and other seasonal viruses. But before we get to that point, the number of cases that is compressed into a short period of time will be fairly large, and may, in weaker health systems, still overwhelm the capacity of that health system.
Yes.
So this was the biggest peak, and after this, we are going to see many more peaks, but they will be smaller. The other pattern that we are predicted to see is one where this was not the biggest peak. The peak that we are going to see next, which India hasn't actually reached yet, the peak that we are going to see next is going to be larger than this peak. That it will be, if we don't practice social distancing, if we have sufficient numbers of people getting out there, then the second peak is going to be larger than what we've seen this time around. And the third approach is that we are going to begin to see a pattern where this was likely to have been the largest peak, and in future, with variable periods of time, we will see similar peaks again. So 3 real patterns, none of them saying that we will not see another peak. And all of this depends on actually the initial models that we saw, which told us that the reproductive number, the ability of the virus to spread is high, somewhere between 2 and 3. And with that, it requires that at least 60% of the population become immune before you will begin to see a reduction in transmission. And that is the idea of herd immunity. It isn't that, necessarily the entire herd has become immune. It is herd protection kicks in when 60% of the population is no longer susceptible to disease, whether they became that way because of infection or because of vaccination.
Thank you. This is very helpful. I'm just going to go a little bit further on that. So what we're saying is there could be three models. One is this was the larger peak and a smaller peaks are following. Second is we should anticipate this kind of peaks going forward, and then and the third model is this is the smaller one, and there will be probably a larger one if people don't do their social distancing correctly. So then I've seen a lot of questions on this. So what do you do? For example, what are the practical implications? Because see, as you know, India is a country where this is not the only problem we have, right? So I'm just going to continue this with you, Cherry, and then come back to Shahid on this, saying, what are the practical implications? I've seen a lot of people who say, should we have allowed train travel? Should we permit opening up of schools? And where do you stop and where do you start? Can you give us some idea from what you feel? And somebody said, I'm going to come to, so I'm just going through the list of questions. So these are the two. What are the human implications of the lockdown ending? And what would be a practical way to end the lockdown, given that, as you know, India, this is not the only problem we have. Then I'll shift to Shahid on a lot on the other stuff.
So there is a lot of debate about what are the right strategies. And given that we've never been in this situation before, all that we are doing is making our best guesstimates. And the way to approach this really is by small, careful interventions where we measure the effect. So whether it is thinking about how a factory opens up for work or how a college or school opens up, we need to measure both the directions that we give for interventions, the ones that we implement ourselves, the compliance with those interventions, and then measure the effect that they have on new cases of disease. What is it that we can control? Some things are controllable. You can definitely do fever screening when people come in to work. We know that fever screening is going to miss 80% of infections, but it is a small effect. Could you do screening of individuals on a regular basis, the so-called random screening in the community? Actually, we know that that has a fairly low yield as well. So can we think about doing antibody testing in people? Are people who have antibodies protected from infection? We know for sure that they are unlikely to be a risk to other people, but are they actually protected from infection, and is this a safe way for them to go back to work? I think this is likely. Shahid mentioned that we don't know what the correlate of protection is, but increasingly we see that it is possible, at least in animal challenge systems, both in hamsters and in primates, that you can induce a protective immune response. And to me, that predicts that we are more likely to have a vaccine available, and that if we really focus on developing either a correlate of protection or a surrogate correlate of protection, we may be able to monitor immune responses to figure out who is protected and for how long. Of course, this will require us to be way more intrusive than we have ever been in the lives of people who are at work. So just to summarize, we have nothing that is 100% solution that we know of right now. I think very intensive monitoring of a number of different things. making sure people who have any symptoms of illness stay home, encourage them to stay home. And that's not limited to just fever and cough. We know that about a quarter of all the SARS-CoV-2 infections come primarily as non-fever, non-respiratory infections. It could be diarrhea, it could be abdominal pain, it could be somebody presenting with a stroke. So anytime anybody has any health issue, they should stay home. Anytime anybody has contact with people who are known to be infected, they should be screened, and we should be focusing very heavily on making sure that we monitor people who are ill and recovered so that we can identify what might be a correlate of protection and then utilize that in our communities as we open.
Terry, you're not answering my question yet. Would you open the school or not?
I would open schools. So the CDC has just brought out guidance on how to open schools. Don't open schools when there is a raging epidemic outside and you have hundreds of cases being in.
Of course, of course.
But when cases have been coming down for a period of at least 2 weeks, you can think about reopening schools. You will stagger shifts, you will have distancing in the classroom, you will move as much online as possible, and you will make sure that people are not in too much contact with each other. So contact sports, definitely not. Exercising outside, absolutely. Move your classes out if it is possible to do so. It's been shown that in China, only one infection was identified as something that was acquired for sure in an outdoor environment. So it is the closed systems that are more of a risk than the great outdoors.
It's actually very important. I didn't realize even myself this particular aspect, which is that the closed systems are the more at-risk ones, and much more so than the outdoor ones. So that's, thanks for that. Shahid, let me come to you now and talk about, this virus is going to be with us, and there are a lot of myths of how to keep ourselves safe. Everything from should we be getting newspapers, should we be, I've seen people putting sanitizers on their vegetables and a lot. Can you help explain very succinctly what should we do? Much more importantly, what should we not do? If you could please help with that.
Okay. Actually, I just recorded something for Times News Network 2 days back on how to deal with newspapers and your veggies and your grocery shopping. So that's interesting.
Okay.
I'll tell you what, we have continued to get newspapers. And I'll tell you what we do. It may sound silly, but I think if you think about it logically, it works. We bring the newspaper in the house with a pair of tongs. We lay it on the floor on an older newspaper and run a dry hot iron on it. So we're not ironing our clothes these days, we're ironing newspapers. And if you think about it, the high temperature is going to destroy all the virus that's on your newspaper. So although there is no confirmed report that newspapers are transmitting the virus, if you really want to be careful about it, follow this. To me, a bigger source of infection, apart from newspaper, are currency notes. Currency notes is something we don't pay attention to. A lot of people have the habit of counting currency notes by putting saliva on their fingers. So try to minimize the use of currency notes. Do credit card, debit card based transactions. But if you get currency notes back from a vendor, or even when you're withdrawing cash from the bank, just don't put it in your purse directly, put it in a plastic bag, and apply the same trick that I have just told you about newspapers. Put the notes between 2 sheets of paper, put on a hot dry iron on it, it's safe to use it. Groceries and all, there are really no confirmed ways the best is to just soak them in water for a while and rinse it really well in running water. All the methods are really designed for bacteria, not really for viruses. One thing you may want to do is to soak your veggies for about, uh, 5 minutes in a tub of 2 liters water plus 2 tablespoons salt and half a cup of vinegar. 5 minutes in this, wash it off. Those of you who have access to potassium permanganate, a 0.1% solution of potassium permanganate works well. But again, all these are for bacteria, not for viruses. Let me get to something else, more general about the outbreak. As an individual, as somebody who's trained to look at viruses, I am really quite scared and disappointed at this time. And I'll tell you why. Because I think as a country, we have converted a public health problem into a law and order problem, which immediately means that there is no trust in the system. People are, when they're moving out, they're being beaten up. We see what's happening on our roads. Hundreds of migrants are walking. They are essentially taking in, the virus from cities to villages. These are people who are not walking because they want to walk. They're walking because they have nothing to look forward to where they were. And that is where the trust comes in. And this is something that Kerala has done so well. Kerala, very early in the outbreak, announced a very handsome economic package. Kerala announced 15,000 crores to tackle the outbreak very early, 20,000 crores, at a time when Government of India had announced only 15,000 crores. And what Kerala was using this money for was not just to spruce up its healthcare infrastructure, but also to take care of people who were out of a job because of the lockdown. People who were vulnerable, people who were not getting food. So kitchens were set up, food was being supplied. They even paid 2 months of advance pension for their pensioners. This really built trust in the system. So people were self-reporting, they were coming to get tested. People were not running away from quarantine centers, which we have seen happen all over the country. So I think trust is a key element which has been missing from the rest of the country. And in the last few days, I don't know if you've seen this or not, the emphasis has shifted almost completely from health to economy. So much so that in the last few days, the regular Ministry of Health briefings have not taken place. Instead, it's the Ministry of Finance briefings that have replaced them. Let us wait and see if the Health Ministry briefings start on Monday or not. If the government is going to shift its focus from health to finance, to economy in a very major way, then I think it's simply sending a message that those who die will die, let's move on. And that I really find to be rather worrisome at this point. As to what we should be doing, I think firstly, we should really empower local administrations to design lockdowns, to design hotspot areas, and to deal with them as they deem fit, with guidance provided to them. This has to become a local problem and cannot be just treated with the same stick for the entire country. Secondly, I think very clear criteria have to be developed and communicated properly. Communication has been a key challenge in this outbreak. And it's very clear by now, based on what we read in the press, that scientific advice has been ignored again and again. So we've gone through 50 plus days of lockdown, yet our doubling time remains at around 14 days. It should have gone down much more than this if we believe any of the models that have been done. Third is to really create funding and appropriate resources to help vulnerable populations. And we see a package that has come out now. Again, it will really depend upon how the package is translated at the ground level. And finally, really a mandatory policy for wearing masks in public. That is absolutely essential. Each one of us have to treat ourselves as infectious, capable of infecting others. So even cloth masks made at home are good enough. Mandatory use of masks in public and all the regular guidelines of washing hands with soap and water. Those who can afford sanitizers, but I don't know how many of us can really afford as a population, how many can afford sanitizers.
Yes.
How many can even afford soap and clean water is another issue, but let us not get there. So these are really things that I would advocate at this time. But to summarize, I'm getting more worried now than I was earlier in the outbreak.
Thank you, Shahid. I think hopefully hopefully we will get to a point where everybody does start wearing masks, because that is something that can be easily done. It is not something that takes a lot of money. It is something that you don't need a mask. You can just cover it with a cloth.
Yeah,
so,
Jogin, I forgot one other thing. May I just add, as part of the trust building, the app Arogya Setu is not helping build trust. It is really eroding trust. And in a pandemic, you can't have the idea going around that while the pandemic is raging, government is keen on being the big brother. So that's another example of eroded trust.
I think Cherry wanted to say something.
Yeah. So, this sounds like a really dismal picture. And I'd just like to point out that a lot of what we hear and see in the media puts this as a killer virus. If we go outside, we are going to die. If we open something up, the world is going to collapse. I'd just like to point out that this virus actually has a low case fatality rate. This is, we have seen many more infectious agents. Most people who are infected with this virus will survive, and the young will do better than the elderly. In India, 10% of our population approximately is over 60 years of age. These are the people who are most vulnerable. It's not like you can say for sure that this infected child, infected young adult with coronavirus is not going to have anything. It is completely unpredictable. Who will react badly? Who will become very sick? But 99% of people who are infected will recover. A proportion of those will require hospitalization, but the bulk of them will not need hospitalization. Some people will not know they have the infection, other people will have mild symptoms, other people will have moderate symptoms, and a small proportion of infected will become very sick. So it's very important to understand that. The reason that we are worrying is because we have no vaccines, we have no treatments, and we are going to have these cases bunched together in a short time frame. And people who could potentially survive with the best medical care may not be able to access it. And there will be consequences, not just for the people who are infected with coronavirus, but people who have other conditions, pre-existing conditions, acute events that happen that the system will not be able to handle because it's busy with coronavirus. So it's very important to understand that this is going to change the world in many ways, but it's not going to completely destroy people and populations.
Very, very good.
Cherry, I do agree with you. And I started out by saying that the population mortality rates are likely to be around 0.5%. So more than 99% people will survive. But it's also a fact that people who are undernourished are not, as immune to all viruses, not just this one.
Sorry,
as
Shahid.
every other virus.
Shahid,
So it's important to.
my entire life.
Yeah,
Okay?
I know.
I worked in slums my entire life, and I think our immune systems are phenomenal. I don't think that we have any evidence at this time that nutrition will play a special role in this particular virus any more than any other infectious disease. In fact, I think bacterial diseases take a much larger toll in malnourished individuals.
Thanks, both of you. This was. I'm going to shift a little bit of this. I have two more things. I see a lot of questions I haven't been following. I hope Ganesh has been following those questions. But I have two specifics that I want to ask both of you. To start with Cherry. Cherry, you talked about testing. Tell us a little bit about what is a current coronavirus test, how long does it take, and if it takes if it takes long, what is the population strategy for testing, and what is the gold standard that we should go with?
Right now, for diagnosing an acute infection, you're looking at the nucleic acid of the virus. So this is at the moment, the RT-PCR test. There are other tests that are aimed at nucleic acid testing that are in late stages of development. There are tests that have been now given emergency use authorization in the US. This is a system called Sherlock. Similar to that, there is a system that has been developed at at IGIB, which is the Institute for Genomics and Integrative Biology, a system called FELUDA, which is also for detecting nucleic acids. This is being scaled up. What we are aiming for is either to detect nucleic acid or to detect antigen. Antigen tests have been developed elsewhere in the world. The quality of those tests is being evaluated by an NGO called FIND, the Foundation for Innovative New Diagnostics. They are evaluating hundreds of tests. And if they tell us that we have a good antigen test, then that becomes an option also for getting tests results back rapidly. Currently, the way RT-PCR tests are set up, you actually spend more time collecting the specimen, transporting the specimen to the laboratory, aliquoting it, processing it, doing the paperwork, than you do doing the test. So the test itself can be done in about 4 hours. You can get the result back the same day. That doesn't happen because of the logistics around the pre-analytic phase and the post-analytic phase of reporting. Antigen tests, I hope, will be a significant advance on this. A lot will depend on the performance of the test. They are usually not as sensitive as PCR tests, which are based on amplification and therefore can detect really tiny amounts of the virus. Sometimes in infectious disease diagnostics, you also use antibody tests where you can measure the first antibody that comes up in response to an infection, that's an IgM antibody. For this particular virus, the IgM antibody appears to come up a little bit later than we've seen in other viral infections. And so far, again, we really don't have a good IgM test. Again, FIND is looking at this. We might have one in the future, but these tests cannot be used for the first week after you develop symptoms. It takes that long for the body to make antibodies and for them to reach a level that is measurable. You also have antibody tests that look at exposure to the virus, not that you have the virus now, but you had it at some time in the past. And those are IgG antibodies, and there are a lot of good tests out there that look at IgG. Some of the rapid tests, which were the lateral flow, little paper strip tests, have failed because they were insufficiently evaluated before being released. This is a lesson to us that if you compromise testing before you make a product available, you will have a product that is not usable and destroys trust in your testing system. And I hope that people will be a little more careful with the next generation of tests that they put out there.
Okay. Yes, thank you. Thank you. I have two more main things and then there's tons of audience questions, so I'll move on to that. Shahid, this is a question for you. There has been lots of talk about the conspiracy theories of where this has originated. We won't talk about the absolute crazy stuff where, the Bill Gates is behind it and all of that. That's not for this audience. But can we talk a little bit about, there has been talk about it originating from the lab in China and all of that. Can you just give a bit of
Well, I mean, forget Bill Gates. We have a union minister who said this 2 days back. And we also have a Nobel laureate, somebody who co-discovered HIV, who's been saying this. So, I mean, if you look at it logically, if this was a virus that was built in a lab, the logic would have demanded that whoever was making it would have used the backbone of another virus that caused disease in humans. You don't find traces of that in here. And when I talked earlier about two key things in the spike protein of this virus, its optimized ability to bind the ACE receptor and also the polybasic cleavage site. These are really missing from the closest nucleotide similarity viruses, which have been isolated from bats and from pangolins.
Yes.
So to say that somebody could have used a bat virus to generate this virus, why would somebody use a bat virus which was never known to cause disease in humans to generate this virus? Would be somebody either really very stupid or somebody very, very smart. I can't figure out which it is. So really, there is no scientific basis for it. The second thing is that whenever you create something in the lab, creation is abrupt. Evolution is not. Evolution shows a slow progression to a given property. And this is what we have seen in this virus. As we have looked at 25,000 sequences that are available now, as we look at the closest sequences that have come from a bat virus and pangolin virus, it's a slow change. What we don't know at this time is whether the virus acquired these capabilities in an animal and then jumped to humans, or a suboptimal virus jumped to humans and then evolved these properties in humans. There is data on both, but there is no data on either. And time will tell as more data gets accumulated as to which one of these hypotheses will work out. But clearly, this is not a virus that was made in a lab.
Thanks, Shahid. That was very good. I also remember you guys at the Welcome DBT Alliance did a webinar known as Bat Ki Baat, which
we didn't do a webinar. We put out an infographic.
Yes. Okay. Yeah. On the Bat Ki Baat. So that was nice.
Somebody wanted to call it Bat Ke Man Ki Baat. And I stepped in and said, no Man Ki Baat here.
Yeah, I know. So that was very interesting. Sherry, I'm going to get, take this opportunity to now then step a little bit forward, take a broader, expansive view. This is my last question, then we move to the audience, right? About the science and what does it take to develop something, especially because we in India, we've not developed a lot. And one of the things that we have developed is something that you were very clearly associated, which is the rotavirus vaccine. So can you help us go through briefly what took it, and more importantly, what was the impact? Because I think for all of us, we're on the board of Ignite and we're singing from the same hymn sheet when we say, if you want a hockey stick impact for investment, there is no better investment in science. So take us through it, and more importantly, the impact of the rotavirus vaccine, please.
Let's start with how long it took.
Yes.
The strain that became the vaccine was discovered in the mid-1980s under the leadership of Dr. M.K. Bhan at AIIMS. And it was licensed as a vaccine in 2014. So usually a vaccine is not developed quickly. It takes years and years of work. So in order to make something into a vaccine, you have to understand the strain that you're working with, and you have to understand the technology that you're using. In the case of the rotavirus vaccine, I don't have an exciting technology story to tell because the technology was one that derives from the 1950s. Now, having said that, where we were when we started to work on this rotavirus vaccine in the early 2000s, to where we are today in terms of the Indian vaccine industry, in terms of Indian science, are two completely different pictures. So the technologies that have become available, that have begun to be applied in India in the last 10 years, are phenomenally different from where we were before. From being, 15 years behind the West, we are now at 2 to 3 years. And what we have is a level of linkage to the vaccine industry and some of the largest vaccine industry in the world that is much more than is seen in academic setups elsewhere. So if we were to think about new vaccines today, and particularly vaccines that are aimed at SARS-CoV-2 or at other new viruses, I think we have unprecedented opportunities. What did the rotavirus example show us? It showed us that if you have academia, industry, government working together, it's possible to get new things done in this country. Dr. Bhan was a completely visionary leader, and he transformed the way government interacted with industry in the biotechnology field. He also brought academics together and said, work together as teams. And for those of you who worked with academics, you might realize that every academic wants to be a star and not a member of a team. So changing that mindset was challenging. But what it allowed us to do once we agreed on how we were going to work together was to do really, really high quality clinical research that had not been done before in the country. So large scale study, multi-site, done with really good coordination. And that allowed us to recruit 7,000 participants in less than 6 months. That allowed us to follow very young children for a period of 2 years with 98% follow-up. Every child that we lost, we knew why we had lost that child and knew that it was something that could not have been prevented. So in terms of how much science has changed, in terms of how much the industry relationship, the government relationship have changed, and the opportunities for clinical research to test new products has changed. I think rotavirus was the pathbreaker that got us there where vaccines are concerned, and I really look forward to what we can do in the future. Just to mention that we are working on changing the regulatory piece, which is the one that was the hardest to handle, but even that is moving now.
Good, fantastic. Do you want to just talk a little bit about the impact of the rotavirus vaccine in terms of lives?
So the rotavirus vaccine, before we had the vaccine, I'd done a burden of disease estimate and modeled how many deaths we could potentially prevent through the vaccine. And we estimated that even with relatively low coverage rates, we could probably save about 30,000 lives per year. Now, we worked on the first rotavirus vaccine with a company in Hyderabad, Biotech. Then we worked on the second vaccine, which was with Serum Institute. And now the entire country has either the Biotech or the Serum Institute vaccine in place. The entire country was covered last year after starting the vaccine introduction program in 2016. We've been doing an impact assessment study to see how the vaccine performed in real life. And it's interesting, but usually when you get a vaccine out there in the clinical trial, you're going to get the best possible results that you can get. And then when you get out in the real world, it doesn't do quite as well.
Yes.
We're finding actually that is not the case. So the vaccine is working as well as it did in clinical trials. So our prediction of 30,000 lives saved every year was probably an underestimate. And we are now looking to see whether we can get a better estimate of how many lives are actually being saved through the vaccination program. But, you know, vaccines are the gift that keeps on giving. Every year, the number of lives that you save just increases. It's cumulative.
Yeah. So that's incredible, absolutely incredible. And I'm going to go on my 60-second soapbox and then hand it off to Ganesh. Because there's a ton of questions. And this is the reason why science takes long. It is a thoughtful, deliberate process. As you've heard from Shahid and Cherry both, there are a lot of unknowns that one has to deal with. But when it clicks like nothing else. And that's the reason why investment in science for any country, especially India, is just non-negotiable. We spend 0.1% of our GDP on science, while everybody else sells for 2.4%. So without that increasing, there's no real way. I mean, Shahid talked about economy getting ahead of health. It's just, if we do that, it's just going to come and bite us. We've seen the examples in the US, and I'm hoping we'll be able to learn from that as well. So with that, I'm going to shift this conversation now to the audience. There will be a ton of questions. Ganesh has been keeping track. And I'm going to go on mute, and Ganesh, over to you.
Thank you, Jogin, and thank you both for it. Absolutely inspiring, because I think the thinking and your articulation were just fantastic. So it's very, very useful. And Jogin, as the father of a scientist, I will 100% agree with you that we need to spend more on science. So there are multiple questions, and I'm going to request our country director, Mrinal, to maybe ask a few of the interesting ones. But let me ask the first three questions based on some broad thematics. The first theme that keeps emerging is, can you help us to understand a little more about this virus? Because somewhere it was mentioned the virus is not very different from what started off in Wuhan in China. But at the same time, we are finding that in India, for instance, I mean, of course, there have been a lot of talk about there is a mutated version of in the West and the South, which are very different. There is mortality rates are, at least from a data point of view, seems to be lower in India than other parts of the world, particularly China. So what is the logic? I mean, is this different types of viruses? And when we talk about vaccines, will we eventually have to create different versions of the vaccine to treat or to prevent various mutations of this virus? Can you kind of illuminate a little more on what is this virus thingy at all?
So since I talked about the isolates, let me handle that. There is no evidence that the virus that is circulating in India is a different strain or a weaker strain. You know, this whole idea of an Indian strain started surfacing when there was only one sequence from India available in the database. And even that one sequence was a virus which was acquired in Wuhan. So one fails to understand how it became an Indian strain. I think it drives from our need to explain why, for example, the mortality is low in India. And there are no clear explanations. But you know, history teaches us things. And if you look at the 1918 flu outbreak and the way that outbreak propagated in India, the flu virus arrived in India on troop ships in the port of Bombay around April around April of 1918. And it really caused devastation in Western India. But as it moved eastwards, it caused less and less devastation. There's no evidence that the virus mutated and became a weaker virus. What did happen was that by the time the transportation systems were slow, and by the time the virus reached Bengal, more people were aware and more people started taking measures to protect themselves. So I think in India also, when we see low mortality, we close down early, and I feel that has an important, that's an important reason for the low mortality that we are seeing. Now, coming to whether the virus is changing and it'll affect vaccine, one thing is that RNA viruses change all the time. It's not something unique to this virus. However, as opposed to other RNA viruses like flu viruses, coronaviruses don't mutate as quickly. And that is because they have an error correcting mechanism in it. Viruses mutate because when the genome replicates, random errors are introduced, and most viruses have no way of correcting these errors. Coronaviruses is one of the largest viruses, RNA viruses known, and it actually has an enzyme that can correct the errors that are introduced during genome replication. So the mutation rate of a coronavirus is something like 100 to 1,000 times less than that of a flu virus. So it is by itself, by the inherent nature of the virus, is that it doesn't mutate very quickly. So within the 5 months that we're talking about, for the virus to have mutated from a highly pathogenic virus to a low pathogenic virus, I don't think that's the case. I think it's that we are more aware. But eventually, I think the virus, once it becomes endemic in the human population, it will adjust itself to the human population and will continue to reduce the mortality that it causes. Because in the end, a dead host is of no value to a virus. So all viruses do that. And I think that's what is going to happen. I really don't think we have much to worry about at this point, whether a vaccine made against the strains circulating today may not be working a year or 2 years from now. I think the possibility of that is very remote. In science, we have learned never to say that it is impossible. We just use the word probability.
Okay, sir. So we will not confuse the improbable with the impossible. But let me ask you both a couple of questions which might take you a little bit out of the scientific field. So feel free to say you won't answer. The first question is, of course, I mean, the constant question we have in SVP, and this is actually articulated again by our board colleague, Ramesh Mirakur. So Ramesh says that, look, this is clearly a disease that was brought by the rich from their global travels, given to the poor. We saw that in Dharavi in Bombay. And of course, then now we are afraid to let the poor into our houses because we are scared that we will get it back from them. And hence we are actually completely killing the livelihood of the poor, and this lockdown is going to aggravate the situation. So the question is that, look, I mean, is this something in this country where migrants have gone back to the villages, maybe carrying symptomatic or asymptomatic versions of the virus. So do you folks think that it's going to be a big issue, that we're not going to come out in this V-shaped recovery we all talk about, that in July we're all back to our restaurants again, but it's going to be a very, very long time to solve this problem? I mean, what do you think as citizens of this country? What can we do about this?
Sherry, you go first. I'll go after you.
Yeah, absolutely. So I think one thing to understand is that everybody is susceptible, and it is likely that people who live in more crowded circumstances are more likely to have virus transmission than those who have the luxury of social distancing. It is also likely that people who are infected are going to be protected from disease. So if you have somebody who has been previously infected, they are actually a very valuable resource. For whether that is someone who works in your house or someone who works in your business, this is a person who for some period of time is likely to be protected from reinfection. We hope that it will be a long enough period of time, but it's looking based on at least SARS and MERS that they will be protected for up to a year. So what we should be doing is thinking rationally about what this means. If you have elderly people at home, if you are over 65, if you have diabetes or hypertension or other cardiovascular complications, if you are immunocompromised in any way, these people must be protected. And they must be protected not only from your maid who comes home, but from younger people in the family. So it's not like you will have one thing for your maid and another thing for your college-going son or daughter, right? So this concept of shielding the elderly is not being applied in Western populations because they have the luxury of social distancing. In our population, I think this is something that is very important for us to think about, that until there is a vaccine, how do we protect the most vulnerable within our families, within our communities, within our country? And there have been discussions around, should you in a slum area build a isolation facility where if you have elderly individuals in a household where young people have gotten the illness, can you move the elderly out of the household and into a place where they can be protected? So we are going to need to think about solutions that are based on the science of transmission and the probability that we will be exposing some people to higher risk than others.
Dr. Jameel?
Yeah, so I think what Sherry said is very important. This community isolation and taking it down to the community level, I think is the key. You can't really put people in quarantine facilities that are themselves very isolated, where they have, places they don't identify with. And that's part of our building trust. So community-run, community-enforced quarantines will have to be done. And this is not going to go away. It's going to be with us, causing disease for some time. So we need to really follow all those measures. I think I'll just stay with that at this point.
Great. So now let me ask you a hot potato question. And it actually goes to this whole point on isolation. I mean, my friend, Mr. Rajiv Bajaj of Bajaj Auto, yesterday he made this, he's been saying this for a very long time, that look, herd immunity and what you said, Dr. Kang was saying that, look, keep those people with comorbidities and elderly people away. is the solution, and we have to open up this country. And we are finding, I mean, historically, it's always been the problem in this country. Morning, I was on Al Jazeera watching this Columbia University scientist. I mean, it was very critical about government action, which is probably driven by political compulsions. The question I have for you is, I mean, there's already this distancing happening between the scientific community, the industrialist community, and of course the government, and the government has its own compulsions. So do you folks think, I mean, coming from the scientific community, that it would be worthwhile to have a consultative platform of all these three constituencies to chart the way forward? Because nobody can get it absolutely right, but surely if there's more consultation, it can make things maybe a little better and maybe a little more palatable or acceptable. Any thoughts on that?
Certainly, I think that's the ideal world, but the question is it happening? And articles that have been published lately show that the government hasn't even listened to the bodies it created itself. The empowered committees that it made, which had scientists and epidemiologists and public health specialists on it. So yes, at least start listening to the advice that you're getting from people you trust. Important. One other thing I might say is that, this idea of social distancing or physical distancing, a better word, is a very alien concept to large parts of India. I was looking at Dharavi, which is, has emerged as the most famous example. There are 8.5 lakh people living in an area which is 2.4 square kilometers. That's roughly 350 persons per square meter. And we are happily propagating that people should stay 1 meter apart. Somebody calculated that you will need, if all Indians were to stay 1 meter apart, you will need a land area which is 7 times that of India at this time. So we have to think of proper strategies and proper scientific strategies based on how the virus transmits to do this distancing.
Absolutely. Okay, I think we have time for maybe one more question. Mrinal, do you have a favorite question from the audience question that you'd like to ask our panel? She's not there. So let me just conclude by saying that, look, I mean, again, back to the last point, I think you mentioned that, and I completely agree with you, sir, because if you look at the US, I mean, they're talking about a quarter of the population of India and 3 times the landmass, and clearly we're going to have problems there. So final question is, I mean, is there any words of advice that you would have for all of us? I mean, people who care for the migrant community are doing our bit as social venture partners to take care of whatever we can, not trying to do the job of the government, but working with government, working with other NGOs, and making some change happen. So thing that we could do, you think, in the next few months to really make some benefits for COVID and this whole situation?
If I can go on that, I think
Please.
Education and communication. So the first thing is, people don't understand why this is happening. This has happened all of a sudden. Things are being imposed on them without trying to build understanding of why this is being done. And I've found in the work that I've done that we frequently, as the English-speaking elite, tend to treat people who are not in our social class like they have an inability to understand. They do not. Some of the most thoughtful people that I've come across are the people that I've worked with in the communities in which I've had the privilege to work. Their understanding is no less than ours. Their ability, their desire to do things for their family is no different from any of us. What you need to do is try and empower them with information. And constantly keep delivering information that is practical and that is actionable. So you can't tell people who share a toilet, or if you have 5 people in a room, practice social distancing. So what is it that they really can do? They can certainly come up with a face covering. You can figure out how to give them opportunities to have sufficient water to be able to wash their hands. Soap is never a limitation, even in slum areas, but water frequently is. So what are the things that you can do that will truly help people? Can you build places? Can you ask for schools to be assigned to be places where older individuals can be cohorted? Or if you decide that you want to take the alternate approach of removing the ill people from the population, can you create like a center where people could stay during the period that they have to be out of circulation? Can you make sure that food is provided, that people are incentivized to be tested and to be isolated? Everyone worries about their livelihoods and their families. How do you empower them to do what is good for public health as well as what is good for their families? If you're removing, the only wage earner from the population from a community for 2 weeks, then how does his family or her family survive during that time? If you can assure them, what's happening now is nobody wants to be tested, because if you are tested, you are labeled and you are stigmatized, you have a sticker on your door, you have people coming to check on you. How do you incentivize someone to be tested and then incentivize them, if they are positive, to stay away from others? These are the kinds of things that we can do. The government operates from a top-down approach. We need to operate from a bottom-up approach to make sure that in limited numbers of people, we offer them everything that we can, and then expand that limited number of people to as much as we are able to handle.
Thank you very much. I think that was...
Couldn't have said better than what Cherry has just said.
Yeah.
I'll just add that, empathy is as important as anything else. Show empathy. India must show Bharat that it cares. It's not happening right now.
That's a fantastic one, sir. And I think I agree completely with that. Completely agree with you. Education and empathy are itself 2 areas that SVP should focus on.
Yes.
And before I hand it back to Jogin for the final words, let me just say that empathy is one reason for the next part. I mean, the next episode, the 6th episode of our Thought Leader series, we're going to showcase one community, which is the 2nd largest employer in this country, and which has received very little empathy from many of us, at least many people in India, to take Dr. Jameel's point. That's the artisan community. So we are going to showcase people who are in the arts, in artisan communities, and make sure that they tell you how they are exploring resilience, and of course seek your help. And that's 2 weeks from now. We'll let you know the dates. And thank you all for attending, and thank you very much to our 2 very, very distinguished scientists. Back to you, Jogin, for the last word.
Thank you. So guys, this was absolutely brilliant. This covered a lot of things. I just wanted to do a quick summary of what we learned about this. So what we've learned is that the virus has a fairly low mortality rate. There's no difference between this one and outside. There will be peaks which will be possible. We don't know how that's going to turn out, but there are reasonable indications to know that it is possible that we are at a peak. The focus on economy way too early is going to just take us back. So we just need to be very, very clear on that. This virus is not from Wuhan lab, at least it's not from a lab. It's not a man-made virus. There are possibilities of making commonsensical approaches to getting out, including some very, very nice things that both of you talked about for schools reopening, for newspapers, the basic commonsensical stuff that we need to do. It is very obvious that our life, at least in the medium term, is going to change. It's not going to come back. So we just have to adapt to that for some time. Again, I end with education, communication, and empathy. These are the three things that we take forward, and this is where communication from scientists is also as important as everything else. So, Shahid, Cherry, anything else that you would want to add to this before I thank you guys? I mean, it was a fantastic session. Thank you so much.
I'll just add.
This together.
Sorry.
Go ahead, Shahid.
No, I'll just add something that I started with, and that is to please stop converting a public health problem into a law and order problem.
Very important, yes. And the whole conversation about India needing to care about Bharat, it has been relevant forever, but now it's much more than before. So, Cherry, you were saying something and I interrupted you.
No, that's fine.
Okay. So thank you, both of you. This was a fantastic session. Thanks a lot. Audience has a lot of questions that came in. I don't think we could go through every one of them, but we will try and see if we can do some collation of those questions, get them answered by you guys offline and distribute them to everybody else.
That's fine.
Because we couldn't get to all of them. So,
good morning and welcome. Sab logon ko namaskar. Sat shri akal. Hello. Welcome.
okay.
I think somebody else has another webinar going on.
Okay. Well,
Thank you.
thank you, love.
Bye.
Thanks a lot,
Thanks,
guys.
everyone.
Bye-bye.